In this lecture, we will discuss the QRS complex, specifically what it represents and how it should normally appear on the EKG. The QRS complex represents ventricular depolarization. You may also hear it referred to as ventricular activation or ventricular excitation. They all mean the same thing. So if you look here, we're saying that our QRS complex, which is this here, okay, this would be our P wave. This is our T wave. We have our PR segment, or PR interval. Okay, this is our PR segment. All right, this would be our ST segment, starting at the point of our J point, which is there. Okay, and then we have our QT interval, all of this. So that's just a quick review. Now our focus here is on the QRS complex. So this big complex there, and it represents ventricular depolarization. Now, the majority of electrical forces during depolarization undergo cancellation, and therefore the QRS is generated by residual non-cancelled potentials. In terms of the general ventricular depolarization sequence, there are three main vectors we should discuss. The first vector represents septal and paraseptal activation. This vector is directed rightward and anteriorly in a left to right direction. It may also appear as a small Q wave at the beginning of some QRS complexes. So if you look here, we're going to go through this sequence, and we're at this first one here where we're talking about the septal and paraseptal activation. And this is directed left to right. So if you look here, this pink arrow here is the first one, and notice going left to right, and this is what represents the septal and paraseptal activation, all right, the first part of our QRS complex. So if we erase this, we'll see that point, all right? Imagine we're in lead 2 here, so if lead 2 is here, we're heading away from it. We'll see this initial negative deflection, which represents a small Q wave, okay? Now, oftentimes you'll hear your colleagues refer to this as septal depolarization, okay, or septal Q waves. That's partly true, although this vector represents more than simply septal depolarization, right? We also mentioned the surrounding areas are being depolarized, okay? So that's just a little nitpicky and not really something too significant. Anyways, let's move to the second vector in the sequence. And this one represents ventricular depolarization of the ventricular free wall, okay? So now we're looking at the ventricular free wall, okay, and the majority of these forces are directed leftward, and they appear as a large R wave on the EKG. All right, so if you look here, this purple vector heading in this direction, leftward, right? This is our left side, this is our right side, okay? Just keep that in mind. So we're heading leftward, and that's the main vector, and it's giving us this large R wave, okay? This big complex here is our R wave as it heads towards that leftward direction and towards that lead, okay? So that's the leftward, and that's ventricular depolarization of the free wall. The third vector represents activation of the posterobasal septum, the posterior ventricles, and the remaining portions of the ventricle that have yet to be depolarized. This is a superiorly oriented vector that can be directed anteriorly or posteriorly. It may be represented as an S wave in the left lateral leads, okay? This is our S wave that we're seeing here. In this lead, you may see it as an R prime wave, a small R prime in some of the right precordial leads. We won't get into that though. But notice here we have this third vector, okay, heading posteriorly, okay, and is depolarizing the posterobasal septum, posterior ventricles, okay, as well as any other area of the ventricle that has yet to be depolarized. Okay, so that's the general sequence in the three waves that we may see on the QRS complex. We talked about the Q wave, this R wave, and the S wave there. Okay, now let's discuss the duration of the QRS complex. You may also hear it referred to as the QRS interval. It represents the duration of ventricular activation. It is measured from the beginning of the first appearing Q or R wave, okay, of the QRS complex to the end of the last wave of the QRS complex, okay. So what do we mean by that? So we mean from the beginning of the complex, right here, until the end. And we're measuring the duration. Remember, when we go left to right, we're measuring time. As we go up and down vertically, we're measuring voltage, okay? So time as we go across, and that's why we're measuring this duration, okay? Also known as the QRS interval, you'll hear it as. Now, the normal duration of the QRS interval in normal adults should be somewhere between 70 to 110 milliseconds. That is about 2 to 3 small boxes. Usually it's about 80 milliseconds. That's in like about 50% of all adults is around 80 milliseconds, but you can have some adults that reach that 110 milliseconds, that upper range, and it's still considered normal. Okay, now it tends to be greater in males than females, as well as in larger and taller individuals compared to smaller and shorter individuals. And just like the PR interval, you want to measure the QRS interval in the lead with the widest QRS complexes. This is because the initial or terminal vectors may be perpendicular to the lead in some axis, which may result in an isoelectric segment and falsely narrows the QRS complex. So the widest QRS complexes are usually in the precordial leads, especially leads V2 and V3. All right, so that's where you should measure them. Okay, so it's important to know that measuring these in the widest QRS complex, because you don't want to get any isoelectric aspect. All right, so imagine that we have a complex here, okay, and our duration is from this point to this point. However, we have another complex that goes like this. All right, so imagine that we're falsely missing some of our QRS complex, that beginning portion here, okay, and that's why we don't want to do that. So look for the precordial leads. V2 and V3 tend to have the widest ones, so that's one area you can look for first. Now, just a little hint for future lectures. If the QRS interval is beyond that normal range, which we said here is about 110, okay, we start thinking about conduction delays, which we call intraventricular conduction delays, okay? So that's any delay that's going on here in the ventricles, okay? And we can also think of other rhythms, so such as those originating in the ventricles, such as VTAC, okay? You can have an idioventricular rhythm. So these sort of things when we start to see wide complexes. All right, next we have the ventricular or QRS axis. And this represents the direction of the mean QRS vector in the frontal plane. It should be directed between -30 and +105 degrees. That is leftward and inferiorly in the frontal plane. Okay, so now we're in this QRS axis between -30 and +105. So to orient yourself, this is 0 degrees, okay, where lead 1, the positive end sits. This would be AVF's positive end at +90. We have plus or minus 180 and -90. And we're saying that the normal ventricular axis, or QRS axis, lies from -30 all the way to +105. Okay, so imagine about right here. So this whole region here is considered normal ventricular or QRS axis. And generally speaking, we think of the QRS axis as shifting leftward, okay? So this would be the right, and we're shifting this way more leftward with age, okay? If you recall, in fetuses in utero, towards the end of the last trimester, the right ventricle is really acting like the left ventricle in adults, okay? It's really the dominant ventricle, and after that first month of age, you start to see things shifting, where the left ventricle starts to take over, the mass of the left ventricle increases, and with age, it starts to shift leftward, okay, as we build and bring more electrical impulses towards the left side of the heart. Now lastly, just a few words on the QRS amplitude, which is the height of the QRS complex, okay? So when we talk about the amplitude, all right, if you take this complex here, we're looking at the height. This could be the height of the R wave. This would be the height of the S wave, okay? So this is the whole height of the QRS complex. That's what we talk about with this amplitude. Now, in general, the QRS complex maximum amplitude values should be no greater than 20 to 30 millimeters in lead 2, or 25 to 30 millimeters in the precordial leads. The minimum amplitude values should not be less than 5 millimeters in the limb leads, or less than 10 millimeters in the precordial leads. Now, the QRS complex, or the amplitude of it, is affected by age, sex, and race. It tends to be greater in males than females, greater in younger and thinner individuals compared to older and obese individuals, greater in African Americans compared to Caucasian individuals, as well as greater in the precordial leads than the limb leads. In general, the QRS voltage will come in handy when we start discussing ventricular hypertrophy and enlargement, in which the QRS amplitude may increase, okay, and then along with conditions that may decrease the QRS amplitude, such as obesity, pericardial effusion, and emphysema. There are also some other factors that can influence the QRS complex, but we won't get into them here. Okay, so let's briefly review what we discussed before we end. So remember, the QRS complex represents ventricular depolarization. We talked about the sequence where we had those three different vectors. We had the first, the septal and paraseptal activation, this vector 1, okay, giving us that initial Q wave. Then we had that ventricular free wall here, this vector, activating that, heading leftward, where we got that large R wave. And then we talked about the posterobasal and septum and the posterior walls and everything else being depolarized by that third vector and can sometimes give that S wave in some leads. Then we talked about the QRS interval, which is also the QRS duration. Normally it should be between 70 and 110 milliseconds, which was about 2 to 3 of those small boxes. Remember, we measure this in the lead with the widest QRS complex, okay, not to miss any isoelectric segments of the interval, okay, and that's often in the precordial leads, and look to V2 and V3 to clue you in first. It tends to be greater in males than females, as well as in larger and taller individuals compared to small and shorter individuals. The QRS axis, we said, is directed between -30 and +105 degrees, right, in this region, leftward and inferiorly, okay, to the left and going down in the frontal plane. And then remember, it shifts leftward with age as we get older. The QRS amplitude, or the height, right, we talked about this height of these, it should be maximum in lead 2, between 20 and 30, and then 25 to 30 millimeters in the precordial leads. The minimum, less than 5, okay, in the limb leads, less than 10 in the precordial leads. Remember, the precordial leads tend to have greater amplitude. Then we said it's greater in males than females, African Americans compared to Caucasians, and then younger and thinner tend to have a greater QRS amplitude than older and obese individuals. Well, that's the end of this lecture. We discussed the QRS complex, specifically what it represents and how it should normally appear on the EKG. I hope you learned something.